Chief Perzada presented a video for us back in January, and we asked him again to talk about long COVID. He does, as another person who does a really good job on Twitter of sort of doing weekly updates about things to be worried about, but also how he, as an individual and as a family, is coping. So he recorded this short 11-minute video for us, and then we're going to have the panel of OCOW experts, including our physician, Dr. Jugnunden, who will be able to answer some questions maybe that raised for Kashif, and he's not here to answer. So let's listen to Dr. Perzada. Thanks.
Hi, my name is Dr. Kashif Perzada. Pleased to present to you some points on long COVID syndrome and some uncertainty that lies ahead for all of us. I'm an emergency physician in Toronto. I work with a group called Mass for Canada, volunteers across the country trying to limit the loss of life from this pandemic. You can find me on Twitter at Cash Prime. Basically, I'm going to briefly go over some of what we know about long COVID. You may not know this, but for SARS-2 and COVID-19 have a number of different phases. The limited upper respiratory syndrome that a lot of you might have gotten in the Omicron wave, that's phase one, and you're very lucky if you didn't go on to the other phases, and that you can thank the vaccines for that. The inflammatory phase is when your lungs and your organs get damaged. The hypercoagulable phase is when blood clots start to develop, people get strokes. The multi-system inflammatory phase children can get. And then, the final phase, which is the long-term phase, the post-acute sequelae phase. Um, so if you got none of these things in just the first one, consider yourself lucky. There's unfortunately a lot of people who haven't been as lucky. What is long COVID? It's fairly hard to define. It isn't fully understood, like what's causing it. There's a bunch of theories. There's no agreed definition, which has been part of the problem regarding this issue. The main symptoms seem to be common across many different people. They seem to focus on fatigue, chest pain, shortness of breath, memory problems, concentration problems. Usually they'll last more than 6 weeks after the infection, and generally post-viral syndromes do last about 6 weeks after, and usually stop after 6 weeks. That includes irritative cough that a lot of people get after viruses. That is not included in these symptoms. It is definitely real. A lot of previously healthy people are disabled by this. People with no history of any kind of illness or mental illness are getting this, and they seem to have a common set of symptoms. Fortunately, the vaccines reduce but do not entirely eliminate risk. So that's one bright spot, but it's still even in a recent study with double vaccinated people, about 10% still got long-term symptoms. An interesting paper just came out recently trying to identify, long COVID sufferers into clusters. One seems to be, mostly pain oriented, joint pain, muscle aches, headaches, fatigue. Another one seems to be mostly cardiovascular. We're seeing a lot of these in the emergency department. People coming in with mysterious chest pain, trouble breathing, that we work up and usually don't find anything. Occasionally, we'll find people with heavily damaged lungs that they didn't even know about, which is quite frightening. Um, and then there's a third cluster, which is a combination of the first two, but with fewer symptoms and hopefully a shorter time that they have the symptoms. Um, what are the causes? Immunologists are furiously working on trying to figure this out. Three theories stand out. One is that getting infected with the COVID-19 virus, with SARS-CoV-2, triggers your immune system to start attacking yourself. So you have antibodies that attack, certain critical proteins in your body. The second possibility is that perhaps you have virus staying in your body and activating your immune system and causing inflammation. A third possibility is that your immune system is getting overactivated. So your T cells, your macrophages are getting influenced by the virus and overactivating and causing inflammation. How common is it? As we mentioned before, I think estimates have been up to 30% of people in the pre-vaccine era. With vaccination, that is lower, thank goodness. But one recent paper found that at about 9.5%. That was after two doses. Studies on what happens after the booster dose, they're still pending. It's still too early to say, since most people just got their doses a couple months ago. But hopefully, fingers crossed, it'll improve. But you have to plan for it not improving, because this is all a new area, and by all accounts, if you have long COVID for over a year, it's probably not going to be going away. So it's not something you want to play around with. And increasingly important people are starting to get it, and people are starting to notice that there's just something not right about what's happening. This is Senator Tim Kaine, Hillary Clinton's former running mate, talking about how people don't like to talk about it. It seems that the recent U.S. State of the Union address was a super spreader event. You're having Supreme Court judges, a large part of the White House off with COVID, and for many of them, it's their second or third infection. So this is becoming more and more common. It's becoming more and more recognized. The key thing is, you do not want to join this cohort. You want to avoid joining them as much as possible until there's better science or better treatments out there. And again, reasons why you should try to avoid getting long COVID and getting COVID in the first place is that there aren't really good defined tests for it. Arguing for benefits is going to be difficult. This has always been the case in medicine for what we call medically unexplained symptoms. A lot of times, patients are gaslit into believing that it is entirely mental health based, which is wrong. But there's no, there's a precedent for that, especially in the people in the chronic fatigue syndrome, the myalgic encephalitis community. They know this problem very well. And if you look at the cost as a precedent, you look at people with chronic fatigue syndrome or myalgic encephalitis. The disability costs alone are fairly significant, often completely disabled as well, depending on the spectrum. And again, there's also a predominance. Mostly it seems that 2/3 of cases seem to be in women. So it's something that will hit middle-aged women much more hard than when it hit men. So that there's an angle there as well. And again, the investigations that we have at our disposal are not very good. Many patients with the sort of the cardiac cluster, we can send them for the full range of tests, including echocardiograms, pulmonary function tests. Very often these will be negative unless they have the lung scarring. There's in the long COVID community, there tests for exotic tests for microclots or panels for autoantibodies, but these are not a standard part. And I think if you showed up to your family doctor with asking for these tests, they'll just look at you with a confused look, because this is not being studied very well. It's not being talked about. The medical community is not fully up to speed on this syndrome, unfortunately. And again, how do we prevent it? I think the best approach is a good defense. Try to avoid getting it in the first place. Avoid getting COVID in the first place. And I think it's entirely possible. This is a nice figure from CIDRAP, University of Minnesota, where they compare the different types of masks. This is why I think removing the mask mandate, especially at the start of our sixth wave, was a terrible idea. It makes a lot of indoor spaces less safe, even when you're wearing an N95 mask, which in the hospital, it's protecting me from catching COVID after seeing hundreds and hundreds of patients. But that was in a well-ventilated hospital. If I go into a poorly ventilated shop or store or workplace, that's not going to protect. It's not an absolute protection. So combine the masking, and effective masking with a good quality tight-fitting masking with ventilation upgrades. A very recent study just came out in Italy showing that incidences were reduced in a classroom where they achieved about 6 air changes an hour, up to 82% reduction. So this is an extremely important factor. Aim for low CO2 levels in your workplace or classroom or shop. If it's not low enough, then build these Corsi-Rosendahl boxes. These are cheap filters that you can attach to a box fan that can effectively filter the air and hopefully keep you safe. The other thing is, really integrate rapid testing into your daily life and work. This is a sample that we do as a family before we do any gatherings. We text each other, rapid test results to make sure that we're not contagious at that moment. The It helps you identify asymptomatic cases and clusters of cases. And remember, even a faint line, very faint line on the test should be considered a positive. There's been some concern about the performance of these tests. I still wouldn't use it as a green light to go to large, indoor gatherings with hundreds of people. I'm still going to avoid those for now. But for small gathering with family, I'll probably still use those. For a small workplace or a team, it's probably useful as well. Maybe it could be used on days when people are having in-person offices. But during upsurges, you should really be trying to minimize that anyways. Really, like I'm really disappointed in the removal of the mask mandates. I'm really surprised that public health authorities went along with this, considering that we're just entering a new surge right now. Really, they should have preserved some of the masking, especially in common areas where immunocompromised, school children, especially young children who can't get vaccinated, have to go, such as in transportation or in schools or in religious gatherings and clinics. So I hope governments will see the light on it, but I'm not optimistic. But it's something that we can still push for. The other thing is, it's really the I know I just spoke to a historian recently about patterns about this. Is that the politicians and some of the members of the public want this to be like a nice movie with a beginning, middle, and ending. Unfortunately, this virus is not giving us that. This is going to be a continuous problem. Just a few weeks ago we were, in the lull phase, and through the cruelty and vagary of variants, we're unfortunately back in an upswing, and precautions and our need to go back, and our shields need to come up. So that's an education campaign that really needs to get to the public and to workplaces as well. Thank you again for indulging me and taking the time to listen. Please reach out to me if there's any questions, and thank you again. Stay safe, everyone.
Posted the video into our YouTube channel already. Link it under the event listing on the OCOW webpage, so you'll be able to see it and share it later as well. Of course, we're recording right now, and we'll have the video up next week. So now I would like to introduce Dr. Jagnandan. He is an occupational health and family physician with an active medical practice for over 25 years. He's a fellow of the Canadian Board of Occupational Medicine, the American College of Occupational and Environmental Medicine, and the College of Family Physicians of Canada. He's been an occupational medicine consultant to OCOW for more than 15 years. He's been involved in many of their large intake clinics, and he is currently on OCOW's COVID response team, providing workplace-related COVID advice. He has a special interest in research ethics and serves as the chair of research ethics for 4 regional hospitals and 1 national healthcare organization. Dr. Jagnandan has presented on occupational health and disability management topics, both at local and international conferences. So thanks, Pravesh, for joining us today. And I don't know if you have any comments. We're interested in your perspectives on COVID from an occupational medicine perspective, and also if you have anything to add with respect to Kashif's video or not. Thanks.
Well, thank you very much for the invitation. I appreciate it. At this time, nothing specific to add, but I'll kind of comment at the end when we're doing the rounds. Some things are common. So my presentation is not as formal as the previous two. Val just asked me to give an overview from what I'm seeing as a physician over the last 2 years. So it's kind of just general stuff and nothing very specific. So my sort of approach to anything when I'm talking to a patient or giving advice is generally I start at the basics. If someone is stressed, I'm going to talk to them about you need to eat well, you need to sleep well, you need to stop using drugs, kind of stuff like that before I get to the highly technical medications and things like that. So when I look at COVID and I look at the 2 years that have passed, I ask myself, what do I need to consider here? And the one thing that comes to my mind, having seen many patients with COVID, and I don't do in-hospital COVID patients, it's basically out-of-hospital workers and patients in my practice. And looking at everything around me, family, friends, immediate family, the community, world at large, I think the one thing is I need to learn to be grateful. And we all need to be grateful and appreciate what we have and learn to say thank you. So we need to slow down, appreciate what we have, appreciate what we achieved. I am grateful that I have a house, I have, internet, and I have a meal, and most of all, I have a job and a work to go to. It's significantly more than what a large percentage of the population, both in Canada and outside of Canada, has. So I think, to me, that's something that we need to stop and reflect on. I think the people in Ukraine would rather have our COVID versus what they have now. I think the 700,000 children that are going to die this year from malaria, those parents would rather have our COVID than the kids dying. So gratefulness, I think, is something all of us must consider. But having said that, it does not mean we don't hold people accountable, we don't do the right thing, and we don't advocate for the right thing. So yes, we have to hold our politicians and our leaders accountable. There's been discussion about masks and why it was lifted now, and it's a discussion on testing. And yes, we have to push for the right thing, and we have to advocate for the right things. But in the background, we have to put it in perspective and still take time to self-reflect, because being grateful and say thank you is good for yourself. So you need to take care of yourself. So that was the first thing. The second thing is, following the presentations, I mean, in terms of COVID itself, like I said, I don't do ICU work, I don't do inpatient hospital work. I do hospital work, but not in the COVID wards. The issues is around long COVID and the long-term effects of COVID. Number one is prevention. So if you don't get COVID, you can never get long-term. You can never get long COVID or the long-term complications. And once again, the basic stuff works. Masking works. Avoiding crowds work. Keeping your social distance works. Being immunized and having the boosters work. When you're symptomatic, being tested works. When it comes to rapid testing, the current guidelines are that you swab the inside of your cheeks, you swab the back of your mouth, and then you swab your nose, hopefully in that order. You're more likely to get better results. And they say if you're symptomatic, repeat it. If you get a negative result, repeat it in 24 to 48 hours. If 2 results are negative, you most likely don't have COVID. The confusion is that many workplaces and many people with the negative COVID test kind of think they're not sick, they're better. No, you're still sick. It's just that you don't have COVID, you have something else. So workplaces need to understand, yeah, the worker doesn't have COVID, but they could have the flu, they could have a pneumonia, bronchitis, sinusitis, or whatever else. So you still need to stay at home and isolate. In terms of the basic stuff that I discussed, I mean, I had to travel to Southern Africa recently, and the total trip time is like 24 hours. The longest plane ride is 11 hours. So you're sitting 11 hours in a plane. I had an N95 foot tested mask. I tried to follow all the precautions. I definitely couldn't sleep with an N95 mask. So, you have to eat, you have to drink. And when I'm sleeping, I just put a surgical mask. The plane was crowded. The airports were definitely crowded. I mean, there was no signs of kind of COVID anywhere when you go through the airports. Having done the trip and come back, the requirement of the hospital is that I need a negative PCR test, and I need to rapid test daily for 14 days. PCR negative, rapid test tested daily for 14 days. And I think about 2 or 3 days ago was my 14th day. It's all negative. So to me, whatever I told you works, because that was a high risk, high sort of, likelihood. If I was going to catch COVID anywhere, that was going to be more than in my clinical practice. So while in Southern Africa, I managed to visit a local occupational medicine clinic, and this was a public clinic that catered more for the laborers, so low income or low middle income group. And long-term COVID was also an issue for this population. I was kind of surprised because I thought it was more first world kind of stuff. Never really looked at it in that way. But yes, so it's not only first world, it's definitely in third world, and they have a very similar problem to us. So currently, when I look at my practice and I look at the referrals to OCAR and what we are seeing in terms of long-term COVID, there are three groups of symptoms. There's the cognitive symptoms, which are the cognitive fog, the slow thinking, the mental fatigue. There's the psychological symptoms, which are, the stress, the anxiety, the PTSD, and the physical symptoms. Physical symptoms are your aches and pains, loss of smell, tachycardia, shortness of breath, all that. So basically three groups, almost everyone's symptoms fits in there. So the question arises, what are we doing with these patients? Very simple. If you have some specific complaint, currently we are going down that route to investigate that complaint. If you have tachycardia, you're going to, get all your cardiac investigations done. You have respiratory things, your lung investigations. Now, lots of these patients, once you've gone that route, they are still symptomatic, either the fatigue or the cognitive fatigue or the aches or pains or the tachycardia that comes and goes, and we can't find anything to diagnose besides, you have long COVID, we have to figure this out. The most important thing is the rehab. The rehab of these patients is different from what we did in the past. In the past, we will encourage people to go out, be physically active, be mentally active, push yourself to the maximum, but we know that doesn't work. It fails. In fact, they get worse. So currently, we would choose a target, say 60% of what you consider to be your maximum now, not what was your normal, pre-COVID. So 60 to, I generally start with 60 to 70% of what you can achieve now. And then you start to gradedly push them to that percent. So if you get someone, if you want them to walk for an hour, that's what they can tolerate now. So you decrease that by 60%. It'll be half an hour, 40 minutes for a walk, and then you measure that and you continue with that, and then you slowly increase that in a measured way, which would mean you increase that by 5 or 10%. The same thing with cognitive function. You're going to start at a far lower level where they are at the current 60 to 70% or 50%. You just need to choose a point, achieve that, and then slowly and increase it as time goes by. The progress is not a straight line. There's a couple of ups and downs, but eventually you find people do improve and they return to function. A little bit more difficult to sell to workplaces, but depending on the workplace, some are easier, some are harder, but so far for most of the time, it's been working. It generally doesn't work in workplaces when there's other issues happening. So, the supervisor or manager was concerned this was a bad worker all along and think they're faking it or whatever, or they want to get rid of the worker. So in circumstances where there's other issues, it makes it more difficult. But generally, if you can get the workplace on side, it works much better. So with OCAR, we've been looking at two unions, looking at the WSIB rejected cases. Myself, occupational health nurse Tracy Furness-Snow, and executive director Patricia Phillips. So these are two big national unions, and in summary, basically, there were diagnostic issues. So early in COVID, getting a diagnosis was a little bit more hard. PCR wasn't readily available. So trying to go back and prove someone had COVID at that time is a little bit difficult. Fast forward, we had rapid testing and we're having the same issue now. I mean, WSIB has said that they will accept, non-tested people for claims. My advice would be to solidify that diagnosis in some way. I tell my patients, I tell workers, take a photograph of that rapid test, send it to your family doctor, contact your family doctor, make sure it's a solid diagnosis in your file. And the reason I say that is because the WSIB cases that were sort of accepted and rejected, lots of them were cut off at day 14, because at day 14, you are supposed to be better and return to work. What we know at day 10 or day 14 in the past, day 10 now, is you're no longer infectious. It does not mean you're not ill. So you're not infectious, but you're still ill. So I would encourage people to solidify that diagnosis in some objective way because of long COVID. The other thing we would want to solidify it is because of the long-term effects of COVID that we don't know. So you may have palpitations and there may be a minor injury to your heart, or there may be a minor injury to your lungs. You may recover fully. What we know is that if there's scar tissue in your heart 20, 30, 40 years from now, you predisposed to cardiac failure. So if you're looking way down the road, you know, if someone's 30 now, 30 years from now, they're 60, they're still relatively young, and they said, you know, cardiac failure, it could have started with COVID. Same thing with the lungs, whether it's bronchiectasis or COPD many years later. So if you can find a way to solidify that diagnosis, that's the best thing to do for now in terms of what's happening now. The other things we saw in the WSIB files, I spoke about the day 14 where WSIB stopped lots of claims. They are starting to overturn some of them, which is good. The ones where we don't have a confirmed diagnosis is a little bit more difficult, so we're battling with that. We've also had claims with immunization side effects. Again, the common side effects are accepted, especially in settings where immunizations were compulsory, like long-term care settings, so it's part of your work requirement. The rare side effects, we're still battling and waiting for the literature to come out to kind of work through these people. What we know, the numbers are great because the people that get COVID and recover are significantly more than the people that end up in hospital. So even if you look at the low end of 10%, you know, we're going to look at, I don't know, 3, 4, 500,000 people in Canada. Those are just some quick reflections on sort of what has been happening over the last 2 years in terms of the COVID work we are doing. And I think it's going to be ongoing for a long time, and our knowledge is evolving, and yeah, that's where we are now. Thank you very much, Val. That's all I need to reflect on for today. Thank you.
Thank you, Pravesh. Yeah, it's interesting, and we're interested in hearing from people too about the impact of the illness, as we talked about in our write-up about the secondary prevention and the tertiary prevention. So the prevention of someone's the secondary prevention can include catching it, so doing testing or having regular testing, and tertiary prevention is how workers are accommodated potentially in coming back to work so that their condition does not get exacerbated and they don't end up more severely disabled, and which has a massive impact on workplaces. I don't know, actually. I have a question on whether you're seeing any of that. I saw a reference about the effect of long COVID on healthcare just yesterday. Are you seeing any of that in your in healthcare as you're experiencing it, that it's having already the impact of the elevated number of cases in healthcare is having long-term effects as well as short-term effects?
Oh, for sure. Yeah. In the hospital setting, we are definitely having staff that are battling with return to work. And again, it fluctuates. It's hard to get it across to the employer because the symptoms fluctuate. And the patients themselves will tell you, you know what, I was very physically active, I should run. Yeah, I was feeling fine. I went for a run. The run was fantastic. But today I'm finished. I can't even do anything. So it is an issue.
Yeah, I've heard or read that too, that people can get wiped out, and that, yeah, that lots resting more than you ever think you ought to, or whatever. It's hard for us. We're all generally going to work, going to get the groceries, going here, going there, and to make yourself rest is actually a lot harder than people realize, I think. Although, of course,
trying to control that activity, even if it's only your household activity that you're doing, you know, shopping or taking care of the kids. Yeah, you have to start somewhere and cut down where you are now to about, you know, 60% or 70% of that, and say that's all I'm going to do for today. And then you have to get your spouse to understand that, or your kids to understand that, which is another issue.
Yeah. So I actually pasted in a link, and I have not validated or peer reviewed this article, but it was quite interesting, recommended by someone I follow on Twitter today, of a study in Spain where they actually found a number of biomarkers, as well as you know, they were looking at groups of symptoms, but they were able to actually fit them into a statistical model that was interesting because in terms of the biomarkers, there'd be things that could then be tested for. So it's a start. It's only a 30 person, well, 30 versus 50, so I guess totally 80, but 30 people with long COVID, but it was able to find what looked like clear patterns of certain markers in the blood at 49 weeks or something like that. So that, not that that's, you know, all of this, what we want to do is prevent it, so we don't have to be looking for the biomarkers of people. And that's, of course, what is the reason for this ongoing series, is to understand the impact and to understand the impact on workplaces, and mostly so we can learn together on how we can prevent it for each other.